All right. Okay. Today it was a hard choice for me actually what to present, because we have doing also different work during the pandemic, and we have developed a couple of actually different methodologies. And well, I myself a bit classified it as I partition it in two parts also. And the first I classified as a lesson learned. It's something that we learned during the 2020. And some of the open questions will also present some work in progress that we are currently doing. And the first work was published in actually last year, but was before mainly in 2020, at the end of 2020. And it had to do with the evaluation of school and non-school related measures in the Netherlands, and how we can use them to control the pandemic. And to give you the the background. So this was a part of the policy advice that we provided to the outbreak management team in the Netherlands, and here are researchers who were involved in this work. I actually did the analysis myself, most of the analysis myself, and the researchers are from the University Medical Center Utrecht, and Chris van Dorp was also involved, and he did a PhD in the Netherlands, but then moved to the US. So. Sorry for the cat. So just the background. So of course it was still early into the pandemic, 2020, and there was still a debate going on about the role of school-based contacts in the epidemiology of SARS-CoV-2. It was not clear how much exactly schools contribute to transmission, and there was always a high priority to keep schools open. But yeah, it was not clear on the other hand, how can we achieve the control of the pandemic and prevent the new pandemic waves after the first pandemic wave. And these are research questions that we ask ourselves, which were also based on the policy advice that we were asked to provide. Is what are the effects of school-based measures, including school closure during the course of the pandemic? And if we want to keep the schools open and but still have the control of the pandemic, how much do we need to reduce other contacts in the society? And what is the importance of different school ages? If you look at these questions, I think they are very much also agree with the questions that were asked in the first talk. And perhaps we used a little bit different methodology that I will describe. So we used a transmission model. Won't go too much into the detail of this model, but it's basically just a simple SEIR, age-structured model. The age structure is shown by this index case. We assume that there is different susceptibility of individuals in different age groups. That's shown here by the parameter beta K. Then we also implemented a few infectious stages. We assume that there are infectivity in different stages is the same, and we just implement several stages to be able to reproduce more realistic infectious periods. And well, infected individuals can either recover or be hospitalized. So in the model, we have 10 age groups. We have 3 kids categories, children categories, 0 to 4-year-old, 5 to 9, and 10 to 19. And then we have age categories of 10 years. And we have 8 hospitalization groups. So we grouped all children into one age category, 0 to 4, 5 to 9, and 10 to 19, because there are quite a few hospitalizations in general in children. And we assume that there are 3 broad susceptibility classes. This was also quite at the beginning of the pandemic, and there were already discussions that children are probably less susceptible than adults and then elderly, but the precise estimates were not yet available. There was some initial review of some initial data that could indicate that children are less susceptible. So we use 3 broad age categories, 0 to 19, 20 to 59, and all individuals who are older than 60 years, and then we had the 3 infectious stages. We also used in this work the contact matrices specific for the Netherlands. I think they were already also, some of this methodology was introduced in the first talk. They are specific to the Netherlands. Netherlands has collected data during the pandemic at certain points. We use the data after the first lockdown, so the contact matrix after the first lockdown, which was also stratified by different, no, I'm sorry, it wasn't certified by setting, but the schools were closed, so we know that the school contacts were not included in that matrix. And we also had the data from before the pandemic, from 2016 and 17, from the same population. And also the data, of course, pre-pandemic data about the school contacts before the pandemic. And I don't have time to go into detail, but I think one of the things that we have done differently in this work is that instead of just implementing this contact matrices, we also in the model, we estimate how these transitions happen, because we know that we go from one level of contacts, before the pandemic, and then we go after the first lockdown, for example, we go to a different contact patterns, but we don't impose, for example, when that transition happens. You can say, well, when lockdown was introduced, but sometimes changes in the behavioral, they happen even earlier, or or they happen faster. So we estimate when the transitions happen and how fast they happen. And we fit the model to do data sources which were available. The first data source is age-stratified hospital admissions, and we use just the data from the first official case during the first 69 days of the pandemic. So this is roughly includes the first wave of the pandemic. And then we used also the age-stratified serological data that was also collected in the Netherlands. And this data was also collected roughly after the first wave of the pandemic. And I think the first thing that we learned, and we confirmed ourselves, that we could estimate from fitting the model to the data, we could estimate that indeed the susceptibility depends on age. And for our broad age groups, we estimated that children are 23% less susceptible than 60-plus-year-olds, and then the middle age category is 60%. The susceptibility of 60% has susceptibility of 60% relative to the oldest age category. We also learned that the probability of hospitalization increases exponentially with age, which you can see in this graph. We have age group and y-axis on the log scale. So further, well, after we fitted the model and we had quite some confidence that at least we can reproduce some of the past epidemiology of SARS-CoV-2, we could start looking at the interventions. So here you see the hospital admissions fitted in different age groups, which are shown in different panels, and red dots are the data. And you see that there are quite a fewer data in children, but quite a lot in older individuals. And we have also the confidence intervals, and the black solid line is the median, I think the median value of the model, the median prediction of the model. And we also reproduce the seroprevalence in different age groups. The dots are the data, and the violent shapes are the model. So after we have fit the model, so what we were asked, the question that we were asked to answer is basically what to do with schools next, and why did the second pandemic wave happen. And I do not have, unfortunately, I didn't include the graph was the full schematic with the pandemic waves, but this is the schematic of how the measures were implemented, and the reproduction values that we estimate, the effective reproduction numbers that we estimate. And so we estimate that it started, was about, reproduction number was close to 3 at the start of the pandemic. Then after the first lockdown, it was reduced to below 1, 2.6. And then there was relaxation of measures in summer 2020. And after that, there was further relaxation at the end of August when schools opened. So the measures were relaxed in the rest of the society, but schools also opened, and we estimated that the reproduction number went above 1. And we were asked if the schools were not open, for example, could we have prevented the second pandemic wave, and specifically also what to do at this point, which was at the end of November. So I'll describe one exercise with could we have prevented the second pandemic wave by not opening schools, and yeah. I won't have time to describe the second part. So just to remind that we want to have the reproduction number below 1 when we introduce the interventions, and we just split because we don't want to model specific interventions like, I don't know, opening shops or allowing, people gather in outside in the restaurants and for example, so we don't want to model that. What we want to model is just the impact of measures on the now effective number of contacts in the school environment and everywhere else. And that's what we have done. And since we estimated the reproduction number using our model, what we can do is an experiment in which we decrease our contacts hypothetically, and at the end of August 2020, when schools just opened and there was relaxation of other measures. And we assume that, for example, that we reduce all other contacts in the society from the level at which they were in August until the maximum reduction that we observed after the first lockdown, because during all the pandemic, it was not possible to reduce the contacts more than during the first lockdown. So we do this exercise and we start with the level of contacts in August, and we reduce it to the level of contacts in April 2020. And we see that the impact on the reproduction number, well, I would say it would be quite large. So in particular, if you would reduce completely all contacts until that level, so if you introduce the lockdown, the rest of society minus schools, we could reduce the reproduction to 0.8, and roughly 60% reduction in contacts would be needed to reach the reproduction number of 1. And on the same hand, if we did this with the school contacts, if we close the school, so when we reduce the contacts in schools, you can interpret this as introducing, for example, partial occupancy in schools, or until there are no contacts at schools, it means that the schools are closed completely. So we did the same, we go from the full 100% contacts in schools until we close schools. And you see that the impact is much smaller in the previous case. We again start with 1.3, but closing schools would reduce after the summer break at the end of August, would only reduce the reproduction number by 10%. And in particular, it would start it would continue to be quite above 1. So from this, we concluded that while closing schools or keeping the schools closed after the summer break would not have prevented the second wave in autumn 2020 in the Netherlands. And also we looked at the impact of closing different types of schools, or let's say breaking contacts between different age groups, 0 to 5-year-olds, 5 to 10, and 10 to 20. And this is the same exercise where you reduce these contacts from the level where they were in August until full closure, so 100% reduction. And you see that, well, in our analysis, at least 0 to 5-year-olds, it almost has no impact trying to do anything with those schools. And the largest impact is still observed if you reduce contacts to 10 to 20-year-olds. And with this, I would like to finish this first part of the talk. And so to summarize what we learned that older school children have the largest impact on transmission. The closing schools after the summer break in August would not have prevented the second wave in autumn 2020. And well, in general, I don't have all the time to discuss, but in general, what we learned that the impact of measures that reduce the school-based contacts depends on the remaining opportunities to reduce non-school-based contacts. What it means that, well, it's very important from the level with which you start. So if the pandemic is just starting, the reproduction number is very high. And even if you try to close the schools completely, that's probably not going to solve all the problems. But in the situations where you're quite close to the reproduction number of 1 and you need still, 15 or 10% reduction or something like that, schools could be a solution. And now I move on to the second part of the talk, where which is still it's still not published. It's actually quite recently submitted on medRxiv a couple of days ago. And if you're interested, you can have a look. So this is and I hope that it addresses some of the still open questions that we are also going to discuss in this meeting. The team composition was largely the same, but was a very important addition of people who actually conducted this work. It's Timo Efam, whom I co-supervised during her PhD. Now she has moved as a postdoc to the group of Mark Lipsich. And Ilse Westerhoff, who is now a PhD student whom I'm co-supervising, she did also some data analysis for this work. And Mui developed the whole model. So how the work started? So we started in roughly at the beginning of last year, and was the modeling in March of the past year. Based on an assignment that Patricia and Ilse got from the Ministry of Education, from the Dutch Ministry of Education, to evaluate risk-based antigen testing policy in secondary schools. And we have been conducting evaluations of the value of this risk-based antigen testing policy and, for example, impact of vaccination in schools and so on. And during this evaluation, a lot of rich data was collected. Probably not as rich as some of the data in the first talk, but still, it was important that allowed us to continue with this work. And so the questions that we are asking now specifically is, well, probably we are convergent towards endemic phase. And the question, what will be the long-term projection of SARS-CoV-2 transmission in secondary schools? Which parameters, which epidemiological parameters drive the seasonal patterns in schools, and what is the expected burden on students in future, and whether we will need any control measures. And so, in brief, we constructed an agent-based model that was that uses data from the pilot study from the past year. So the pilot study allowed us to collect data, detailed data on school characteristics and on the contact network between students and teachers within and outside schools. So the pilot study was conducted between January and April 2021. About 25 secondary schools, representative secondary schools in the Netherlands were invited. And so the evaluation of risk-based antigen policy allowed us to collect data on the cases, on the SARS-CoV-2 cases in schools and on transmission within schools. And this, just for those who doesn't know, this testing policies, if one index case is identified within a school, then close contacts within the same class or outside of the class within the school, or even outside of the school are identified, and they are offered the antigen testing on the same day, and also offered the repeat antigen testing 3 to 5 days later. And students and teachers also filled in detailed questionnaires about their contacts. And so in the school, in the model, we have like a school with 900, roughly 50 students and 72 teachers. One day is divided into 3 different periods where we have within school contacts. And it's the first 8 hours, and then the next 8 hours it's outside the school related contacts. And also there can be outside school unrelated contacts, so importations basically into the school. And the last 8 hours is just nights, so when there are no contacts. So for those who is interested, the definition of the contact is a conversation of about more than 15 minutes within 1.5 meter distance, or a physical touch. And so we collected basically data about contact network of students within schools. So how many contacts they have within their own class, or with students from other grades within the class. So we also collected data within school contacts between teachers and students. And finally, we also had information about school-related contacts outside school, because students meet each other outside of school, and in the model we have a few contacts outside school. So one student, for example, meets on average 2 other students outside of school, and teachers did not report to have any contacts with each other outside of schools. We also use a constant importation rate into the schools in our simulations. So the transmission model is quite simple. So basically also the students and teachers can be susceptible or vaccinated, and then they develop, if they're infected, they can develop either symptomatic or asymptomatic infection, and then they recover. And importantly here, the immunity waning is also is already important. So recovered individuals can lose their immunity and they become susceptible again to infection. The transmission, we implement direct transmission of susceptible individuals due to direct contact, but we also implemented a kind of aerosol transmission where susceptible students and teachers can be infected within the same class during super spreading events, which are quite rare and occur in approximately, I think, 10% of different of all transmission events. And we start with the dynamics of the Omicron variant, and we implemented, we used certain assumptions about what the epidemiological characteristics of the Omicron are. In particular, it has a high transmissibility, 40–60% with respect to the Delta variant, shorter incubation period, if I'm not mistaken, 60% reduction with respect to the wild type, and it has, of course, a high degree of immune escape after vaccination, implemented as a reduction in susceptibility against reduction in the vaccine efficacy in reducing susceptibility against infection. And we also implement this seasonality. So we define winter and summer periods when the reproduction number, during the winter period, the reproduction number is higher, and during the summer period, it's lower. So the waning of immunity, just in brief, immunity, sterilizing immunity wanes, and we assume in the baseline that the average duration of sterilizing immunity is 9 months. And after that, people return to the 75% of their original susceptibility. And they are also less symptomatic after, so there is a decrease in probability of symptomatic infections after each reinfection. So at baseline—
Ganna, just to say you've got about a minute, 2 minutes left.
Okay, well, I'll move on. So here it's, these are the patterns that we predict will occur in the next 30 months. So this is the first Omicron wave, and then we see that there will be quite a large outbreaks in autumn period and smaller outbreaks in winter period. So this shaded areas show the winter times, and this is summertime. So we predict seasonal outbreaks in autumn, larger seasonal outbreaks in autumn. But overall, based on our assumptions, the burden is not so high. We don't introduce any other variants, etc. So the number of the prevalence of symptomatic students would be about 2.9% only. Of total number of students would be larger, but of symptomatic 2.9%. We also explored what is the importance of different epidemiological parameters on the patterns, on the seasonal patterns, and by far the most important one is the immunity waning. So depending on how fast the immunity wanes, you can, if it wanes very fast, even after 3 months, you could get even more outbreaks. So you could have like a high, an outbreak in autumn, but then also another outbreak in spring. And we looked at different interventions that could be useful. And in short, because I don't have time, so we evaluated the regular weekly screening twice a week, annual booster vaccination, and also class quarantine, so quarantine of close contacts. And the interventions that reduce the health burden the most are the annual booster vaccination and screening. And so this is a reduction in number of symptomatic student days, which is the highest. And they also have, these two interventions also have the higher cost benefit. So they prevent most infections and with least students absent. And with this, I would like to finish. So the second part, so we predict, or the model predicts that we will have seasonal patterns with dominant autumn outbreaks and smaller winter outbreaks. The prevalence of symptomatic infections 2.9%, duration of sterilizing immunity is the key parameter to understand these patterns, and screening and annual booster vaccination are the interventions that could be useful in future to control infections in schools. Thanks. So I'd like to answer questions, or if you have time, or if not, then.
Great. Thanks, Ganna. So that I think there's one question from Jasmina in the chat, but can I suggest that maybe you can answer that in the chat?
So your result, older children contribute more to infections. Is that because of modeling increased social mixing, there's larger class size in secondary schools, or do you take into account their vaccination status and modeled efficacy of it, which would mitigate this? So, our conclusion was based on when vaccination of the high importance of secondary schools was for the pre-vaccination period, and indeed it's based on that these students have more contacts. So in 0 to 5 year olds, at least from the contact matrices that we have, for example, students or children in general, they have a smaller number of contacts, and also the primary schools report smaller number of contacts than secondary schools. That's why in our analysis, we assume the same susceptibility within all children 0 to 20 year olds, but because they have higher number of contacts, they basically also contribute more to transmission. And very interesting extension to regarding after vaccination, but maybe we can discuss this during open questions, because I would have to think what the interpretation would be later.
Great, thank you. If anyone else has any more questions, then feel free to put it in the chat, and I'm sure we can either come back to them later, or Ganna can write a response in the chat.